Okay, so can you all see my screen? If you just confirm in the chat that you can see my screen, I'm perfect. Okay, good. So we'll go now through the ankle fractures. Nice, didn't go. What's wrong with that? And we aim to make this easy for every one of you. So I understand that every one of you is dealing with ankle fracture every day. There's no single orthopedic surgeon who doesn't or don't deal with ankle fractures. This is where I come from. My name is Mohammed Hashim. I'm a foot and ankle consultant at Northwest London, Wilson Park and Heatherwood Hospital. And this is elective hub where I come from, Heatherwood Hospital at Ascot. This is the YouTube channel where you find all the videos and all the education activities we share. It's between my personal channel, Hashim's educational channel, and also be my official channel. Okay, so to start with, we are not here to speak about simple principles of ankle fracture. Every one of you is an expert in dealing with ankle fracture from a very junior level to a very senior level. Ankle fracture is second or third commonest injury comes to the trauma unit or the trauma emergency. The point I'm coming to give you in this lecture is just how not to miss an injury and how to deal properly and promptly with it. So not to miss an ankle fracture, you have to have a weight-bearing X-rays. So normal X-rays, supine X-rays are not acceptable because easily you can miss, number one, a very subtle fracture, number two, a very stable fracture. So weight-bearing X-ray will give you a physiological status when the patient put all the weight on the foot. And the tricky point here, you need to be sure that the patient has put his weight on the foot while taking the X-rays. Some of the patient, because you have to remember that this ankle or this foot is painful. Sometimes the patient doesn't put actual weight on it. Yeah, he's standing. It's a standing X-ray, and the huge difference between standing X-ray and weight-bearing X-ray. Weight-bearing X-ray when the patient intentionally put weight on the injured limb. So this is the actual physiological situation, and you can easily spot a subtle fracture, and you can easily spot an unstable fracture. The problem, you need to be sure from the patient himself that he did put weight while they're taking the X-ray, not just a simple standing X-ray. We don't aim for a standing X-ray, we aim for a weight-bearing X-ray. Remember that if you worried about syndesmotic injury, that is the commonest external rotation stress radiograph. Basically, the patient will be on the couch, keeping the foot hanging from the end of the couch in an external rotation position, and this is by definition stresses the syndesmosis. So you can easily spot any subtle syndesmotic injury. You have to remember that deltoid is two parts, superficial and deep, and the superficial deltoid ligament is the main restraint against valgus deformity, and the deep deltoid is mainly against the rotational anterolateral telar displacement. So when you never miss that it may be no bony injury in a rotational injury because basically the failure wasn't in the bone on the medial side, but was in the deep deltoid. So deltoid is superficial and deep. Superficial is mainly about the movement in the coronal plane, which will be the valgus movement of the ankle. It's a restraint against the valgus, but the deep deltoid is mainly against the rotational deformity. So it's a primary restraint against anterolateral talar displacement. So when you see a patient with a rotational ankle fracture, like syndesmotic injury, like high fibular injury, Weber C, Mesinovo fracture very proximal in the neck of the fibula, remember that even if you couldn't see another bony injury in the ankle ring, it could be the deltoid, not the bone, especially the deep deltoid. And you can easily spot that by stressing the ankle, putting the ankle in a valgus position or putting the ankle in an external rotation position and take an X-ray. Or you can spot that if a weight-bearing X-ray was enlarged or widened medial clear space more than 5 mm. So normally you have the medial clear space equal to the superior clear space. And when you see that the medial clear space widened more than 5 mm with an element of rotational injury on the lateral side, you have to spot that there is a medial injury, and this medial injury will be in the deep deltoid, even if there is no medial malleolar fracture. Remember that we diagnose the syndesmosis in a proper Mort's view by measuring the tibiofibular overlap and the clear space. And I'll show you this in a minute on the X-ray. We have to look into the Shenton line, we have to look into the dim sign, and we have to look into the talocrural angle. And all of them is here. So when you have a proper Mort's view, you can easily spot the medial clear space. So this is a medial clear space. It should be equal to the superior clear space, and it should be less than 5 mm. If it is more than 5 mm, especially if there is a rotational injury, either as a syndesmosis, high fibula, or very proximal fibula like the Messinov fracture, you can spot easily that there is a deep deltoid injury here. This is the Shenton line of the ankle equal to the Shenton line in the hip. So basically, this Shenton line shows you that the ankle morts is this conformation. The ankle morts is congruent. This is the dim sign, and this is easily a ring which gives you an idea about the fibular length. And with disturbed, as you can see, with disturbed dim sign, this means the fibular length, the fibula is short or malrotated. Then talocrural angle, if you come to the proximal talar dome articular surface, you put an perpendicular line and measure the angle between the tips of the line through the tips of the malleoli, medial and lateral malleoli, compare in relation to this perpendicular angle, it should be around 80. If it's increased like that, so like this now, if you imagine that we put over the talar body or talar dome, we put a line, we draw a perpendicular line over this line, then we draw a line between the tip of the malleoli, measuring the angle between this line, the talocrural line, and the perpendicular. If this angle is below 80 or above 90, so we speak about a disturbed talocrural angle, and this means the fibular length is not right. If it is increased, this means the fibula is short. If it's decreased, means the fibula is long. So again, when we have a look, firstly, we're looking into medial clear space, looking into the intact Shenton line, looking into the dim sign to diagnose if there is fibular shortening. Then we measure the talocrural angle, so line along the talar dome, perpendicular line on it, and then a line across from the tip of the medial to tip of the lateral malleoli, and we measure the angle between this line and the perpendicular line on the Shenton line. If this angle should be about 80, if it's below 79 or more than 87, so we know that the fibular length is not right. So if it's less than 79, this means the fibula is long. If it's beyond 87, this means the fibula is short. Then if you look here in a proper Mort's view, you can see a clear space between the tibia and the fibula, and you can see an overlap between the fibula and the tibia. And this gives you an idea how is your syndesmosis. So if the clear space is more than 10 mm, this means this tibia and this syndesmotic diastasis or syndesmotic injury. And if this clear space less than 6 mm, this means again there is a syndesmotic injury or diastasis. So again, because this is the most important bit of this lecture, is how to diagnose a subtle ankle fracture or a subtle syndesmotic injury. It's not about how to diagnose a malleolar fracture or bimalleolar fracture, because you are all expert in this. The point is how to diagnose a very subtle fracture, very subtle syndesmotic injury, which can be easily missed. So again, weight-bearing views and a proper mortise views. What we are looking into the medial clear space and the intact Shenton line to diagnose if there is any medial injury or not. We're looking into the tibiofibular clear space and tibiofibular overlap to diagnose syndesmotic injury. We're looking into dim sign to diagnose any fibular shortening, and we're looking into the talocrural angle to diagnose the fibular length, either short or long. Again, a line across the intact Shenton line, perpendicular line on top of it, and then you draw a line from the tip of mid to tip of medial malleolus to tip of lateral malleolus. The angle between it and the perpendicular should be around 80. If it is less than 79 or more than 87, means your fibula either long or short. I hope this is clear. If you want to check the position, if you have a very proper lateral X-ray like this one on the right, and you want to see if your fibula is inside this incisura, the tibial incisura or not, means the fibula is inside the syndesmosis or not, you can easily draw this line from front to back of the tibia, and if you make it into 2/3 and 1/3, the fibula should be in the back 2/3. And this is in a proper lateral view. This is where your fibula should sit, because this is where the incisura of the tibia is. Classification of ankle fracture. All of us know about Weber or Weber classification, and this is depend on the level of fracture and in relation to the syndesmosis. And basically, this is more of a descriptive classification and give us a guide for the treatment. So we know that type 1 is very stable when it's mainly a coronal plane deformity or a coronal plane injury, and at that time there will be an avulsion fracture at the distal fibula below the syndesmosis. B is across the syndesmosis, and C is above the syndesmosis. Both of them are coronal plane injury. This is an axial plane or rotational injury, and that's why this is the most risky one, and this is the one which needs a fixation definitely. This one, though it is an intra-articular fracture, but this is not a weight-bearing articular surface. So all what we aim for is to be sure that the ankle is stable through a weight-bearing X-ray. And if your ankle is stable, all what you need is to keep the patient in a cast for a week, then allow the patient to weight bear in a boot, and that's it. Same for the syndesmotic injury, because while your injury or fibular fracture is at the syndesmotic level, the syndesmosis is still intact, the ring is still intact, and so there is no risk about displacement or instability. So you just get an X-ray in weight-bearing X-ray and another weight-bearing X-ray in a week. And if there is no displacement on weight-bearing, you keep your patient in a boot weight-bearing, and you are not worried about instability or displacement. This one is by definition a rotational injury, so there is no point to wait, because for this to happen, the ankle should be injured at two sides of the ring, and this by definition needs a fixation. So Weber classification, though it is a very simple one, but it's a very important one to guide us what this patient will need. If it is a Weber A or Weber B, this means it's more of an coronal plane injury, and this is by definition stable fractures. You need just to ensure that it is stable by weight-bearing X-ray on diagnosis and a weight-bearing X-ray in a week. And if there is no displacement, these fractures are stable, and all what you need is just to keep the patient in a boot and allow him to weight bear. And they will heal, even it takes time, it will heal, because you are sure that the ankle ring isn't injured in more than one place, and it is a stable fracture by definition. This one is by definition a rotational injury, and basically it has a higher fibular fracture because the fibula has been fixed on a long lever arm, and this means that the ankle ring is injured in two places, and this by definition will need a fixation to stabilize the ankle. Lauge-Hansen, and there's a lot of debates about the Lauge-Hansen, and I will give you Lauge-Hansen in a very, very simple terms, makes you never ever miss a type of injury over Lauge-Hansen. Lauge-Hansen based on 3 points. Point number 1, is the patient had a direct or indirect trauma? Number 2, what was the position of the foot at time of the injury? Was it supinated or pronated? And we agreed before about what is supination and what's pronation. And basically, what is supination is a plantar flexion at the ankle, inversion at the hind foot, and adduction at the forefoot. And pronation is dorsiflexion at the ankle, abduction at the forefoot, and eversion in the hind foot. So the second thing Lauge-Hansen depend on in the classification, what was the position of the foot at time of the injury? Was it plantar flexed, inverted, and adducted, which is supination, or was it dorsiflexed, everted, and abducted in the pronation? Then the third element, or the third point where the classification depends on what was the direction of the force applied to the foot. This foot has a translational movement or a rotational movement. So if it's a translational force, this gives either adduction if the foot is supinated or abduction if the foot is pronated. And if it is a rotational movement, will be an external rotation either in supination or in pronation. So again, to understand Lauge-Hansen, you need to understand what it's about. And Lauge-Hansen basically is about, is the injury direct or indirect? How was the position of the foot at the time of the injury? Was it supinated or pronated? And then what was the direction of the force applied to the foot? Was it a rotational injury or a translational or force or injury? And there is few rules for you to understand Lauge-Hansen. You don't need to remember anything. You need to understand. It's not about remembering what's supination, adduction, what's pronation, abduction, what's supination, external rotation, what's pronation, external rotation. No. Once you stick to these rules, you can easily classify any fracture according to Lauge-Hansen without remembering any names. You need to understand that tension side fails first, and this failure either will be a ligamentous injury or avulsion fracture. You need to understand that compression side fails last, and it will be either an oblique fracture because it's a compression force, or will be a comminution at the fracture side. So the tension side will fail first. So the first injury will be failure at the tension side, and this failure will be either, because it's a failure in tension, will be either avulsion of bone or ligament rupture. Compression side will be a compression force, and it happens last. So the compression side will be injured last, and will be either in the form of oblique fracture or a comminution. You need to remember that supination equal lateral tension and medial compression, and pronation equal lateral tension, medial tension and lateral compression. So with any foot, you see that the injury on the medial side is tension injury, and on the lateral side is compression injury. This was a pronated foot at the time of trauma. At any fracture, any X-ray, any fracture you see in an X-ray, and the tension was on the lateral side and the compression was in the medial side, you remember that this foot was supinated at the time of the injury. So again, tension side fails first, and it fails in tension, so it either avulsion of the bone or rupture of the ligament. Compression side fails last, and it fails in compression. That's why it either an oblique fracture or a comminution. Remember that supination equal that the tension is on the lateral side and the compression is on the medial side, and pronation equal the reverse, which means medial on the tension side and compression on the lateral side. Remember that rotational force equals syndesmotic injury. So when you see a syndesmotic injury, you understand that this injury is rotational, it's not translational. You remember that posterior mal is part of the syndesmosis. So the Volkmann's fragment is part of the syndesmosis, because the most important for us is the posterior inferior talofibular ligament, which is attached to the Volkmann's fragment in the tibia. And when you see a posterior mal fracture, this fracture is a rotational injury fracture by definition, except if this patient has an axial load in a plantar flexed foot, which is very, very rare. And that's why in an isolated posterior malleolus fracture, you need to speak to your patient and get a detailed history about mechanism of injury. How was his foot? How was the mechanism of trauma? To be sure it was an axial load, not a rotational load. And this is only if your posterior mal is isolated fracture. Any association of injury with by posterior mal, you don't need to ask. This is a rotational injury by definition. When you see an isolated posterior mal, you need to go back to your patient, speak to him or her, get a detailed history, ensure that the injury was an axial loading, not a rotational injury, and this is very rare. Any abduction injury equal a pilon fracture, and I will explain this in a minute. Remember the ring. Ankle is not a simple joint, it's a ring. And ring injuries are not always bony. Sometimes ligamentous injury explain the tension side failure, not a bony injury. I hope this is very clear, very, very important. We'll relay on this in the next slides. So Lauge-Hansen has classified the injuries in the ankle into 4 types: 2 supination, 2 pronation, supination adduction, supination external rotation, and pronation abduction and pronation external rotation. Again, we will not remember any word. Supination, we know that from supination, this means tension is on the lateral side, compression is in the medial side. So the first thing to fail will be the fibula, and it will fail either in an avulsion, which is low transverse fracture, or rupture to the lateral ligaments. Then the next stage after fibular failure will be failure. This is the tension side, which fails first. Second side, which will fail last, will be the compression side, which is the medial mal, which will have a vertical fracture. And the problem with supination adduction, if the amount of forces is enough to cause supination adduction injury, it may cause an anteromedial marginal impaction, which is pilon fracture. So supination adduction is pilon fracture or fracture of the tibial plafond by definition. So once you see a fracture that you suspect it is a supination adduction injury, please get a CT, because it's not uncommon to find an anterior medial marginal impaction or anterior medial comminution in the tibial plafond. Supination external rotation, again, tension side will be still lateral. So the first point to fail will be the fibula, either with a short oblique or a spiral fracture from anterior inferior to posterior superior. Then external rotation start to happen after. So tension side, lateral first fails, external rotation start to happen, and external rotation goes from front to back. So first thing to fail in the syndesmosis, because we externally rotating, the first thing to fail will be either the anterior inferior talofibular or the T-low fracture, and I'll show you this in a minute. Then secondly, if the force is enough, we'll get the interosseous ligament rupture. Then if the force is more and more, we'll get the posterior inferior talofibular ligament to rupture and or the posterior mal to fracture. Then end by compression side, which will be on the medial aspect, and you will find either the transverse fracture or disruption of the deltoid ligament. Again, supination equal tension on the lateral, compression on the medial. If supination adduction start with failure in tension on the lateral side, failure in compression on the medial side with an anterior medial marginal impaction or pilon fracture. Supination external rotation, again, tension will be on the lateral side, fibula will fail into tension, then the medial side will fail into compression. Between them, the external rotation element where the syndesmosis will fail in sequence, starting with anterior because it's an external rotation. Anterior fails first in the form of anterior inferior talofibular ligament rupture or T-low fracture, then intraosseous ligament rupture, then posterior inferior talofibular ligament or posterior mal fracture. If we come to the pronation side, reverse. So in the pronation, the tension will be on the medial side and the compression will be on the lateral side. So again, when you see an X-ray with tension on the medial side, you know this is a pronation. And if there is no rotational element, it's pronation abduction, which means tension on the medial side in the form of avulsion fracture from the medial mal or rupture of the deltoid ligament. And then after that, compression of the fibula, which will equal highly comminuted fracture in a high level like Weber C. Pronation external rotation, same story. So the tension will be on the medial side, compression on the lateral side, and rotational failure will be in the syndesmosis. So the medial side fail in, again, either avulsion of the medial mal or rupture of the deltoid. Rotational element, because it's still external rotation, so will fail sequentially between anterior inferior talofibular or T-low fracture, intraosseous rupture, then posterior inferior talofibular or posterior mal fracture, and end by a compression over the fibula, which is causing, again, Weber C or very high fibular neck fracture Misinovo. Remember that with any pronation external rotation, you need to examine the whole fibula because it's not uncommon to have the injury at the proximal fibula or fibular neck. Then there is special named fragments you need to know about. So you can see from here up, ignore the writing, remember the images. So the anterolateral aspect of the tibia is called T-low. And as we said, if anterior inferior talofibular fails, it either fails by rupture of the ligament or by avulsion of the T-low fragment from the anterolateral tibia. Then on the other side, it's the anteromedial aspect of the fibula, which is called the Wigstaff fragment. And again, in rare condition, you may see that the anterior injury of the syndesmosis is either a T-low fracture from the anterolateral tibia, a rupture of anterior inferior talofibular ligament, or an avulsion from the anteromedial fibula, which is the Wigstaff fragment. In the back, the injury will be either posterolateral aspect of the tibia, which is called the Volkmann's fracture or Volkmann's fragment, or tear of the posterior inferior talofibular ligament, or still we didn't have the name for the posterior medial fibular fractures, but yeah, we're waiting for one of you to name it, or we soonly will name it with some evidence. So Wigstaff is avulsion of the anterior fibula by the anterior inferior talofibular. T-low is avulsion from the anterior tibia by, again, the anterior inferior talofibular. Volkmann's fracture is avulsion from the posterior tibia by the posterior inferior talofibular. And Bosworth fracture dislocation is basically, as we mentioned from a minute ago, this means the fibula is posteriorly dislocated out of the tibia incisora. Then Debetrine fracture, which is another name for Weber C or high suprasyndesmotic fibular fracture. Haragashi classification is classified the posterior mal in the last like 20 years. All the direction, all the interest goes to the posterior mal. The posterior mal was early very underestimated. We just deal with it like if it's less than 25% of the articular surface, means it affects the stability of the ankle posteriorly. If it's less than 25, ignore it. But then we came to know that this is not the true. The actual situation in the posterior malfracture is an expression of a syndesmotic injury, unless proven otherwise. And as I told you, 95% of posterior malfracture are a form of syndesmotic injury, and 5% will be just an axial loading fracture of the posterior mal. That's why we start to look very carefully into the syndesmosis in the last 10 or 20 years by Haragashi classification and by Meso-Malloy. We'll go in a minute. Both of them looked into the posterior mal. Haragashi and Meso-Malloy looked into the posterior mal and give it more consideration and start to speak about types of fracture. Haragashi has made his classification based on a CT study and classified into 3 types. As you see, type number 1 is just the posterior lateral fragment, and this is you see more often, and this is mostly because of rotational injury and failure posteriorly rather than the posterior inferior tiliofibral fails. It just avulses the Volkmann's fragment. Then type 2, which say that there is a posterior lateral fragment with a medial extension, so you actually have 2 fragments, one posterior medial, one posterior lateral. Then type 3, when there is only small shell of bone, and this is just a very minimal avulsion which you don't need to care about. So type 1 posterior lateral, type 2 posterior lateral and posterior medial extension, and type 3 just wide and thin fragment. Then Meso-Malloy from Liverpool looked very specifically into this and classified into 3 types. So type number 1 when is just an avulsion from the back. Sorry. Avulsion from the back, and this is with the syndesmotic injury. Then type 2, which is a rotation, they called it rotational pilon, when there is a posterior medial or posterior medial and posterior lateral fragment because of a rotational injury. Then type 3, which they call axial loading pilon. So avulsion injury, rotational pilon, and axial loading pilon. So avulsion injury when just the posterior lateral fragment has avulsed. Sometimes it's very small, doesn't need anything to be done for it. And if this significantly avulsed and displaced, you need to do a posterolateral fixation for a posterolateral approach. Come to B. I'm sorry, 2. So 2A and 2B, and 2 we call both of them as rotational pilon fracture. 2A when it's only posterolateral, and this is we need fixation from posterolateral fragment. For this rotational pilon, you have to fix it. There's no option, because it's not about the posterior malfragment itself, but about the rotational injury of the ankle and the instability. If you have a posterolateral, which is 2A, you will go to fix this from posterolateral approach with a posterolateral plate. And if you have 2B, which will be a posteromedial and a posterolateral, you need to fix it from either a posteromedial or medial posteromedial approach, and I will mention this to you in a minute. And when you're fixing this type 2B, which is a rotational pilon with a posteromedial and posterolateral, their recommendation according to the anatomical study is to fix the medial first, and this by definition will get the lateral reduced, then you can fix the lateral. You cannot do the reverse. So you need to fix the medial, then the lateral. So that's why you go from posteromedial approach, because it gives you an easy access to both posteromedial and posterolateral. Then the last one, which is an axial load pilon, and this is pilon by definition is a fracture of the tibial plafond, and this will need fixation from the back and mainly from posteromedial approach. So the good thing about Meso-Malloy is an anatomical study. It looks into medial malleolus fracture as an anatomical injury. So look into the mechanism of injury and easily guide you what approach should you use. So either an avulsion injury, or a rotational pilon fracture, or an axial load pilon fracture. Avulsion injury will need a fixation from the posterolateral side. Rotational pilon will be either 2A or 2B. 2A if it's only posterolateral, 2B if it's posterolateral and posteromedial. 2A will need fixation from posterolateral approach. 2B will need fixation from both posteromedial and posteromedial or medial posteromedial. And you have to start with fixation of the medial posteromedial fragment first, then the posterolateral fragment. And type 3 is pilon by definition, axial loading pilon by definition, and you need to do a robust fixation from posteromedial approach to this fragment. So when will you fix your ankle? And you find a lot of debates in the trauma meetings and handovers about shall we be fixing this ankle or not. So if you're looking into open reduction internal fixation indication, let me just check if you have any question before I go. Okay, that's good. So if you're looking into the indication for open reduction internal fixation of ankle, number one, any talar displacement is not acceptable. We agreed from the last lecture that the ankle is a very congruent joint, and this is why the osteoarthritis, the primary osteoarthritis, is very low incident in ankle. But this goes to the opposite side if you have any talar shift or talar displacement, because only 1 mm of talar shift will reduce the contact pressure between the tibio-talar joint and make the tibio-talar pressure, the contact pressure at the tibio-talar joint to increase by about 42%. So imagine only 1 mm of talar shift will increase the pressure, contact pressures at the tibio-talar by about 42%. Remember that at any time you have two injuries to the ankle ring, you have to fix this ankle because it is unstable by definition. Definitely any open fracture and posterior mal fragment, we have two options. If it is an isolated posterior mal because of an axial loading injury, this is the one when the rule of 25% or less come into consideration. This is by definition type 3 mesomalloy classification, which is axial loading pilon. And this when you look into the stability of the posterior ankle. And if it's less than 25, you can ignore. If more than 25, you can do. But you need to be sure that this is an isolated posterior mal. There is no other injuries in the ankle ring. Any functional bimalleolar fracture, which means it's not only bimalleolar bony injury, it could be one side bony, one side ligamentous. This is again is two sides injury of the ring and needs an open reduction internal fixation. So what the guideline says, so Boston 2016 came to say that you have to look into the soft tissue. The ankle fracture is a soft tissue injury with bone fracture, or both bone broken inside. So you have to assess the skin integrity and neurovascular status. You have to look into the patient medical comorbidities because it will affect the way of fixation. It will affect the post-operative care. It will affect the prognosis and outcomes. So patient is if patient is diabetic, if patient have a peripheral neuropathy, peripheral vascular disease, osteoporosis, or patient is a smoker, you need to warn this patient that I will need to do a double fixation. I need to fix as stronger as I can because your ankle won't be healing nicely, and the prognosis is not that good. Risks of infection and complication are higher by even the double in something like diabetes or smoking. You have to do an urgent reduction and splinting. It's a joint. It has to be back in place as early as possible to maintain the viability of the articular surface and articular cartilage. You have to recheck X-rays and neurovascular status once you reduce the ankle, which is done everywhere. What's the aim from open reduction? What we aim by open reduction internally fixing? So firstly, you need to make a backbone to build on. So your strut or backbone will be the lateral column, which is the fibula. So the first thing to do with any ankle open reduction internal fixation is to restore the fibular length and rotation to build on. You cannot build on a mal-reduced fibula or a shortened or a lengthened fibula. You have to get your fibular length perfectly back. You have to get your fibular rotation perfectly back. You have to get your fibula inside the tibial incisura, so you can build upon this lateral column once it is stabilized in an anatomical reduction. Once your fibula is anatomically reduced, all fractures should reduce normally if your ankle ring is intact, because basically the ankle mortise is one piece. It just have three columns, but in harmony. Once you get one column reduced, the other two columns should go back to normal unless there is something is blocking or stopping the reduction. You have to restore the medial column because the medial column is not a weight-bearing area, but it's a very important restraint. Without the medial column intact, your talar will be tilted. So you have to restore the medial column. You have to fix the posterior mal if there's any other injury in the ring, because this will fix your syndesmosis. And there is a large debate between, shall we fix the posterior mal only without syndesmotic fixation, or shall we support the posterior mal fixation with some sort of syndesmotic fixation, either with screws or tight ropes? And this is a big debate. But once you stabilize your posterior mal, get it reduced anatomically, well fixed or buttressed in place, your syndesmosis should be stable. Remember that syndesmosis is not a bone, it's a joint. Even if it is a fibrotic joint or a fibrous joint, you have to restore it to the anatomy. That's why the old practice with syndesmotic screws though it is still doing the job, and the evidence says that the results from the syndesmotic screws versus the tightrope are comparable. You need to understand that the syndesmotic fixation using a screw is not anatomical, because it is a joint and you will just sticking a screw across this joint, so stopping the movement there. Anatomical studies has shown from Malloy as well, from Liverpool, has shown that the fibula has a range of motion inside the tibial incisura. So there is some movement inside the syndesmosis in all direction. Internally, externally, it moves about 10 degrees. Antero-posterior, it moves about 3 to 4 mm. Superior inferior, it moves about 3 mm. And lateral widening out and in about 2 mm. So again, syndesmosis is not a bone, it is a fibrous joint with minimal movement inside, and anatomically, to have a normal ankle function, you have to regain the syndesmosis anatomy. The anatomical studies shown that the syndesmosis, the fibula moves inside the syndesmosis into all directions. So rotating internally, externally about 10 degrees, moving antero-posterior about 3 to 5 degrees, moving superior inferiorly about 2 to 3 degree mm, and lateral widening or coming out and in is about 2 mm. And logically, if you go and fix the syndesmosis with a screw, you just stop all this movement. So this is non-anatomical, though the evidence still support that this is where regain the syndesmosis and will regain the ankle function, and the results and outcomes coming from that is not bad. So it's still comparable to a tightrope. The good thing about the tightrope, if it is done properly and both 100 lines under properly, they can maintain this movement going on. So it is a form of anatomical fixation of the syndesmosis. Your ankle X-ray has to be assessed very, very carefully while you're doing your operation intraoperative. You need to be sure that you restored your fibular length, your fibular rotation. You need to be sure that the dim sign is back and there is no disturbance or disruption of the ring. You need to be sure that the Shinton line is restored again. You need to be sure that the tibial clear space is less than 5 mm and the overlap is more than 10 mm. You need to be sure that your clear spaces are normal. So come to the fixation. If we look about the fixation, remember that as we said, fibula is the reference point. So you have to get your fibula back, and the fibula, once the fibula is back, anatomically, you can build everything in the ankle based upon that. If you have a spiral oblique fracture, remember that it's a long segment fracture, and the best to fix this is with a lag screw, just to eliminate all the movement, all the stresses, all the deforming forces, and then you can neutralize this with a plate. If it's a short segment, a small plate can do the job. If it's a large segment, spiral oblique fracture, remember that you need a lag and neutralization. If you use if it's a transverse fracture, remember you need a stronger plate, and I advise all of you to use the LCB-DCB from Synthesis. This is the strongest plate. I've used different systems, and I can say to you, there is nothing like the LCB-DCB in the distal fibula or the anatomical fibular plate, either from Synthesis or from Accomate. All the other systems are nice, are good, but not in the fibular plate, like Lavender, like Paragon. All this stuff, they are slim, they are low profile, they are VA looking, but at the end of the day, they are very flimsy. And if it's a long segment, they cannot do the job for you. So if you have a long segment, if you are not sure about the quality of the bone and fixation, go for LCB-DCB, either from Accomate or Synthesis. Remember, if the fracture is Weber C and a bit proximal, remember that the SPN is in your way. So be very careful in dissecting there and getting the SPN away from the way of your reduction and fixation. If you're fixing the medial mal, remember that the most important problem with the medial mal is that because of the anatomical structure of the medial mal, the periosteum over the medial mal is under tension. And once the medial mal fractures, this periosteum rolls into the fracture site. And that's why you have to get all the periosteum out of the fracture site. You have to clean your fracture site to be sure that the union will happen. So again, because medial mal is like that, periosteum normally is under tension. Once the medial mal fractures, the periosteum goes inside the fracture site and stop the reduction, the anatomical reduction, and lead to non-union or delayed union. So the most important when you're fixing a medial mal is to get all the soft tissue out of the fracture site, clean all the periosteum and remove it, and ensure that your anatomical reduction doesn't have any soft tissue interposition. You can put 2 screws, and remember you have to pre-operatively analyze nicely where is the fracture. Is the fracture in this the whole medial mal, or it's an anterior colliculus or posterior colliculus? So where is the line of your fracture? Because the screws shouldn't be like a very brilliant parallel and nicely on the X-ray. The most important is to get your screws perpendicular on the fracture side. So it's not always the position of the screws which is going parallel to each other in the lateral and very in like one screw in the anteromedial and anteroposterior plane. No, the point is ignore the X-ray. To get the fracture reduced and nicely fixed, you need to get the screws, the 2 small cancellous screws, perpendicular on your fracture line wherever the fracture line is. If you're putting your screws, there is a debate again, shall I use a 35 or 40 length cancellous screws? My advice to you is to aim to the Pfizer scar. This is the Pfizer scar you see on the right side, because this is a dense plate of bone, and the hold of the screws will be very good. So if I'm putting 2 screws, I'll put the screws up to here, one here and one here, and my aim will be this Pfizer plate because it's a dense sclerotic bone which will have a good hold for the screws, rather than getting a very long screw which is just float into the medulla without any hold. If you have an oblique fracture the medial mal, you definitely need an anti-gliding blade to stop it. And remember that the anti-gliding blade, you need your fixation to be just proximal to the apex of the fracture to do the anti-gliding function. For the posterior mal, the main idea is to buttress it, because it is held by ligaments from all around. All what you need, it doesn't allow it to slip up or to displace posteriorly. So you're aiming to buttress the posterior mal. And to have this done properly, you have to aim to have a blade fixing the apex of the fracture, and the screw or whatever you're holding with to be is just at the top of the apex. Remember that for the medial mal and for the posterior mal, buttressing means it's holding proximal. You don't need to put any screws distant to the fracture side, because the idea of the buttressing is to stop any anti-gliding of the fracture, nothing more. If we go to the syndesmosis and we spend a few minutes around the syndesmosis, you have screws or tight ropes. You need, when you're fixing the syndesmosis, to keep the foot in a neutral dorsiflexion, unless you don't have the sensitivity of tightening the tightrope. You can put your ankle. So if you are aggressive and you tighten the tightrope and you don't have this sensitivity to know that this is where your fibula needs to stop, and you're worried about over tightening, put your ankle in a dorsiflexion, in a forced dorsiflexion. This will not allow you to over tighten. If you have the sensitivity, so the ideal is to keep the foot in neutral dorsiflexion. But if you're worried about over tightening, you don't have this sense, you can easily put the ankle in forced dorsiflexion, and this will stop you from over tightening if you don't have this sense. You have to have a reasonable tension, so not over tighten, not over loose, and you have to avoid over tension definitely, because basically the over tension will move your fibula a bit posteriorly, and this will make your fibula appear short and will add to a talar tilt. So what the literature says about the fixation. So 2011, they found that regarding the syndesmotic screws versus the tightrope, they found that, about the syndesmotic screws, they found that keeping the syndesmotic screws or removing them end by a similar outcomes. There is no problem of keeping the broken screws in. You can remove them at 4 months if they are still intact, or remove it below 8 weeks if they start to have if there is a tibiofibular. No, if you remove it at 8 weeks, this will end by a tibiofibular diastasis. So first literature review is from Archives of Orthopedics and Trauma 2011, and this was speaking about keeping the screws or removing them. All days until the recent few years, we always remove the screws, even they are broken. And even some companies like Paragon has made a screw with a pivot in the middle, which allow you to remove it from medial and lateral, because it was the common practice to remove the broken screws. This literature review says that the outcomes is similar, either you remove or not. And if you remove it before 8 weeks, the syndesmosis ligaments isn't healed yet, and this will end by tibiofibular diastasis. And if you remove at 4 months, they may reduce your dorsiflexion because you left it for a long time. How to put your syndesmotic screws? So you always put it from posterior to anterior with 25 or 30 degrees posterior. Your hand is dropped down, and you go from posterior to anterior, because this is where the anatomical side of the fibula. The fibula is posterior to the tibia, and you have to definitely tibial to the tibial plafond, not to pull the fibula up or down. So if imagine this is the tibial plafond and I go with syndesmotic screws up, I will be pulling the fibula up. If I pull it down, I'll be pulling the fibula down, and this will be either shortening the fibula or lengthening. But just to pull the fibula to the tibia, you need to be parallel to the tibial plafond. Shall you use tricortical or forecortical? Again, another debate. Tricortical is the ideal. But forecortical, you use it either if the bone quality is not good in diabetic, or if you're planning to remove them. So the four cortices give you the option to remove from medial and lateral. So either you put tricortical or quadricortical. This depends on what you're aiming for. Either your bone quality is not good or the patient is diabetic and you need a more robust fixation, you can go to quadricortical, so 4 cortices. Or if you're planning to remove it at some point, so you will need to remove it from medial and lateral. Remember, this is a positional screw, it's not a compression screw. So you have to be a fully threaded cortical screw. You can use either 3.5 or 4.5, but remember, it's not a lag screw, it's not a compression screw. Otherwise, you will over tighten the syndesmosis, and this will end into a poor results. Remember that the screw will loosen in 15% and will break in another 15%. So don't worry if you have to warn your patient or to educate your patient that don't worry if the screw starts to be loose at some point or to break at some point, because once you regain your normal movement, there is no stresses over the screw will get easily broken and get easily loosened. The 2 small fragment screws, if there is a high fibular fracture, such as a Messinevaux injury, because with a Messinevaux injury, as we told, this a rotational injury by definition. So all what you need is to maintain the syndesmosis. So either use a 2 small fragment screws or use a 2-hole plate to fix the syndesmosis. So post 12 speaks about the management of ankle fracture, and they say that what we emphasized earlier, that stable Weber B ankle fracture should be treated with analgesia splinting and patient allowed to be full weight bearing. Where the fracture stability is uncertain but position is acceptable, you can mobilize non-weight bearing, review in 2 weeks, and then weight bear X-rays to inform that, to be sure that the stability is still maintained. Always check the syndesmosis stability during doing an open reduction internal fixation, and the way to do that is push-pull test, which is we call cotton test. So you put the screwdriver against the tibia, you put the bone hook against the fibula, you pull the fibula away from the tibia and take an X-ray. And if your syndesmosis is opening or diastasis, diastating and or the talar space is widening, this means the syndesmosis is not intact. The other way is to stress the foot in external rotation and take an X-ray. And if your syndesmosis is opening, this means it needs a fixation. The surgical patient should be full weight bearing as tolerated, and this has been supported now by the WAX trial, which has been published 2024 in the Lancet. And I advise all of you to go and read the WAX trial, because it pushes to early weight bear these patients, and it show a pragmatic non-inferiority trial, randomized control trial between weight bearing and non-weight bearing post ankle fixation, and they found that early weight bearing is not inferior to late weight bearing. No consensus of removal of syndesmotic screw, as we discussed before. No consensus on the VTE prophylaxis. Advise your patient on functional recovery and rehab, and return to work on sports and driving as early as possible. Nasir et al. In Journal of Trauma in 2011 found that ankle fracture treated operatively has an increased post-operative complication if the patient is a smoker. And as you can see, the smoking can get deep infection higher 6 times than normal individual. Diabetes mellitus, if the reduction is unsatisfactory, if the fracture pattern is more complicated. So it's very, very important to mention to your patient that without stopping the smoking, the results of ankle fixation, whatever you do for him, will be very poor. The prognosis will be very poor. Complication will be very high. And there is no question that diabetic and neuropathic patient will have a poor outcome and poor results. So quickly we'll go through the approaches. So the posterolateral approach, so your skin incision will be midway between the posterior aspect, posterior border of the fibula and the tendo Achilles, or between the posterior aspect of the lateral malleolus and tendo Achilles. Be careful that 8 to 9 centimeter from the tip of the tuberosity will be your sural nerve running there. You be careful about the Shuran nerve and the peroneal artery here, and then you go between the peronei, as you can see on this side, peronei and FHL. Remember that FHL at this area will be a fleshy fibers, not a tendon. You just get it away, and then you go across the periosteum to the back of the tibia. Remember that you have the posterior inferior tibiofibular here, and remember that there is a lot of perforators from the peroneal artery running there, which they are inevitably injured, and that's why posterolateral approach is not that good anatomical approach, because it injured the perforators of the peroneal artery or even the peroneal artery itself. And there's another anatomical studies from Liverpool from Lyndon Mason about this. You can go and read it. Medial posteromedial, so you go over the tip post, so just behind the posterior border of the medial malleolus. So once you go, you open, you be careful that this will be your tip post. You open the shades of the tip post, you pull the tip post to the medial side, you open the bed of the tip post, and you go from there. On your lateral side will be the neurovascular bundle and the flexor digitorum, and on the medial side will be the tip post, and then you can expose all the posteromedial tibia. The risks here is in the tip post, complication of problems of the tip post post-operative, and definitely the neurovascular injury. Posteromedial or traditional, this was the medial posteromedial. So you go very medial, so just over the tip post and through the tip post bed. The traditional posteromedial is opposite the posterolateral. So your skin incision will be midway between the medial border of the Achilles and the medial mal. You go here in between them. This is a very, very nice, very, very extensile approach, very easy approach to see the whole posterior tibia. And then you dissect, superficial dissection, you cut the fascia, and then you go between the FDL and the tibial nerve and the neurovascular bundle on one side, FHL on one side, and then you go and you can see the whole posterior tibia very easily, and a very safe approach. All what you need to be careful about the neurovascular bundle under your retractors. You have to have a good assessment to hold this in hand. So deep dissection on the lateral side will be FHL, on the medial side will be FDL with the neurovascular bundle. Easily you see the tibial nerve running under your hand. Release the tibial nerve all the way down until you reach to the ankle. Keep the tibial nerve secure under the FDL, and go dissect subperiosteally, remove all the periosteum, and you can or dissect subperiosteally and get all the periosteum away from the bone, and you can see beautifully all the posterior tibia, and you can fix posteromedial, posterolateral very easy. It's a very common approach I'm using in my practice, and I advise all of you to try it. And thank you so much. So any questions, I'm more than happy to answer it. I hope it is clear and it gives you something different. Ankle fracture is not nothing new to you. I know every one of you is practicing ankle fracture fixation and management and fixation every day. All what I tried to shed light on is what's easily missed. What can you do differently to properly manage your ankle fracture? I hope the whole course was useful for all of you. You got something new from it. I hope I was able to deliver the message nicely. Both in the question and the chat, any question you want, and even not about this lecture, about all the lectures, I'm more than happy to answer it. Speak loudly, guys. Don't worry. There is no silly question. Ask whatever you want to ask. Or I'll be very happy if all of you understand every and each point, and there's nothing unclear. Thanks, Rafat. It's my pleasure. Okay, good guys. So again, same story. You will get a feedback link once we finish this lecture. Please put in the feedback everything you feel good, everything you feel bad. Your feedback is very, very important to me. I'll take everything on board, and this will be reflect on the next course. We planning primarily to start the next course by mid-Feb or late Feb, because the guys are going to the FRCS Part A examination in the first week or two of Feb. So we aim to start by end Feb or early March and we'll speak about reconstruction. So we've done the basic science, we've done the foot and ankle, and I think the third one will be reconstruction through hip, knee, and shoulder arthroplasty, ankle arthroplasty as well. And I promise you of a very useful one, very, very fruitful one, which you'll find something different than when what you read in the box. But the feedback, you will receive a certificate once the feedback is there. Thank you so much for attending all the lectures. 7 lectures is not short, but I tried my best to make it concise to what you need to know and to give you something new. All the best in your exams for who will appear for the exam in February for part A or part B. All the best in your practical life. I'm more than happy to receive any of your question at any time. Again, I put my email and phone number. I'm happy to receive all your questions, formally or informally, don't worry. And yeah, I will see you by end Feb or early March with reconstruction. Good luck, guys, and have a very good evening, and see you soon.